So we are going to open the meeting for Mason County Board of Health. It's the regular meeting, July 24th, 3 p.m. and we will have introductions.
Let me start.
Sure.
Kathy McDowell's Shelton council member.
Gary Plews, I'm representing the county fire commissioners.
Okay.
Dave Wyndham, administrator.
Randy Netherland, county.
Kevin Chudy, county.
And Peggy Van Buskirk with Hospital District 2. And
Lydia Buchheit, Mason County Public Health. Allison Smallwood, Mason County Public Health.
Alex Pacey, Mason County Environmental Health.
Tom Davis.
go ahead. Tom Davis, citizen.
Ben Johnson, Mason County Public.
Okay. So, thank you everyone for coming, and I would entertain a motion to approve the agenda.
Madam Chair, I move we approve the agenda as presented.
Second.
All those in favor?
Aye.
Aye.
Unanimously approved. Okay, and I would entertain a motion to approve the minutes. There's 2 sets of minutes, either together or separate, I don't care.
March and May's.
Yeah.
I will move that we accept March 2018, May's 2018 minutes as read.
Second.
All those in favor?
Aye.
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 Okay, so health officers report,
Dr. Yu isn't here,
right?
so I think when we get to Lydia's, we'll talk about the syringe exchange piece.
Okay.
I know that Scott wanted to make sure we talk about that this time,
Right.
and we've done some work as far as grant work on that. So we'll come to that when we come to Lydia's piece,
Okay.
which actually is now.
Next.
Okay, so I'm going to start with, were there any questions on the report that I sent out that anybody had? You had a question about the veterans on the...
Yeah, I just wanted to know where the data was coming from, because it conflicts a bit with my own informal count, and I figured we were using the same sources, but I'll take it up as time.
Okay, great. And then I have been, there was a link on the report, and I don't know how many got a chance to click it and see it, but we did a partnership, I'll let Ben explain it, with the Skokomish tribe, and he'll kind of explain what we did, and you can watch a little quick video up there.
Yeah, thank you, Liddy. So we had an opportunity 2 or 3 months ago, actually. Dr. Yu had asked our department to come up with a syringe pickup video, and we did that. We did it really quite well and really quite quickly. But at the same time, I was thinking about another opportunity that we had to work with a tribal partner, and that was the Skokomish tribe, who at just about the same time called us and wanted to meet with us about their Safe Streets program and wanted to do a syringe pickup in their communities. So we asked them if they would be willing to be part of this video. So we partnered with their Safe Streets program, and you can see we also partnered with our regional Timberland Library, and Mason Web TV helped us with the video shoot. We went out to Skokomish. We had one of the parents out there volunteered her children to be in the video. It was really kind of cool, really kind of fun. We had the person from the library. Her name is Erica Leitonen, something like that. Sorry with the last name. She helped out. And Abe Gardner helped out a little bit. He actually was there that day too, and he told me we were using the wrong style of syringe, so we had to change that out. Something I didn't know. So we got there. The director did her job. I was the producer, and we came up with a short 3-minute video that we're going to also put on our county website. So I wanted to show that to you and just kind of thank everybody that was involved. And I was representing the Substance Abuse Prevention Coalition. So. The sound, we couldn't get it through here. There was a couple meetings before this, so it's going to be off the computer. A little bit tough to hear, but here we go. We don't have sound.
Yeah, you do.
That's a needle, Tommy. We don't want to touch that, okay? We gotta get something to pick it up. Finding a needle in your neighborhood can be quite concerning. If a used needle or sharp is not disposed of correctly, it can be a danger to you, your pets, and to other people. A simple prick or worse injuries can lead to infections like hepatitis B, hepatitis C, and HIV. Luckily, with a few household items, needles can be disposed of safely. First, you are going to need a rigid container, such as a water bottle, with a secure lid. If one is available, a plastic laundry detergent bottle with its lid also works. You'll need gloves. If you don't have access to medical gloves, you can use gardening gloves or kitchen gloves. If none are available, use whatever you can to protect your hands. You'll need something to pick up the syringe. We recommend needle nose pliers or tongs, but a napkin will also work if that is all you have. And you will need a permanent marker and duct tape. It is important to take the container to the needle and not the other way around. This limits the possibility of an accident occurring. If the needle seems to be stuck in the ground, use a stick to pry it out. With the pliers, pick up the syringe in the middle of the barrel with the needle pointing away from you. Put it in the container with the sharp end first. If there are lids, use your pliers to put them in the container as well. Once everything is in the container, take the lid and screw it on tightly. Use your duct tape to secure the lid, wrapping the tape around. Once the lid is secure, mark the bottle sharps. Do not recycle. After it has been marked and taped, you can legally throw it in the garbage. If you happen to be near Skokomish, you can dispose of the needle at the nearby clinic. For more information, contact your local health department.
Is it? I'm going to make it quick. I think it was probably under 3 minutes, and that was kind of our goal. So,
She didn't wear gloves.
oh, she didn't what she was doing. Well, and you know, one of the things that I think we're trying to get the message out is people can do this, and yes, you're right. Work for that.
Advertisements. That's how we
It's
can
a
afford,
huge
that's how we can
sponsorship.
afford to bring you the quality.
Yeah. So it's probably a little bit more real world, trying to get it out of parks. We have them everywhere, so the goal is to get the message out there, except now we're going to have 2 videos up, and with really the same type of message. So. Any questions? Or I have one other update, the air duster update. I was here, I think, last meeting or 2 meetings ago, and I was asked to get to all the stores, and we're asking the store owners to either lock up the air duster or put the air dusters behind the counter. And there's really only about 6 or 7 stores that offer air dusters, the smaller convenience stores. Of course, the larger ones have it. And a few of them just had no idea what they were dealing with, but I really believe that the majority of them knew why they were selling the air duster and what people were doing with it. So, not that everybody agreed to do it, but they said they would do something with it. And I'll maybe check back in another few months. So, except a small portion actually sold them. Most people don't.
Thank you, Jim. So, then
Scott had asked for an update, just to bring an update on what's happening with the syringe exchange progress, what we're doing with that. So basically we're looking for funding. We did all of our research on, what the costs were. We met with the different syringe exchanges in Kitsap County, in Thurston County, and in Grays Harbor County, our surrounding counties, kind of got some information from them, saw what they were doing. did some work on a container, getting a container that we'll be able to have up at our landfill here in Mason County that'll be specific for containers of syringes, and that is the least expensive way of doing it. Stericycle is quite costly, and some counties are paying $70,000 and $80,000 for their containers, but we've got a nice, inexpensive way to do it and have already set that up with the landfill. And so we're waiting on hearing about the Cascade Pacific Alliance, which was going to put out an RFP for some of the Medicaid transformation money and to be able to apply there. So the application went in last Monday. Whew, it was huge and quite complex, but got that in, and we will hear by mid next month whether or not we received it and how much money. It's kind of a complex process that they're doing with the Medicaid transformation money, so it's a little difficult. They claimed they were only giving probably around 70,000 to groups, but we fit into a couple of different groups, and I'm more thinking they're going to give us a lot more. They're very anxious to have Mason County have a syringe exchange because we are one of the few that does not have a syringe exchange, so it would be profitable for us to have it. But we also proposed it a little differently than just a syringe exchange in the RFP. We proposed it as a substance use mobile outreach. So we're expanding kind of what it would be doing besides just exchanging syringes. It fits totally in with our opioid response plan that's been going on for a couple of years. And it's going to be a tighter working with all the partners in the community that are offering substance use disorder services, and those that are doing recovery services as well, other types of recovery services. So we're going to use it more as an outreach, and hopefully we'll see how it goes. But that's kind of what we propose to them, that it's going to be an opportunity to, so it's written as, our plan is to develop and implement a substance use mobile outreach, SUMO, program. We've actually got an idea for the logo. That will have syringe exchange as the major component of the program. It will be a fixed site mobile clinic, so it'll be, that will be open twice a week to start for 3 to 4 hours at 2 to 4 locations around the county. The goal will be to offer harm reduction interventions and recovery supports to reach the most at-risk SUD population in Mason County. This population would include injection drug users and individuals using syringe exchange, homeless populations, and individuals living in rural areas with limited access to opioid use disorder treatment. We plan to staff the program with a minimum of 2 staff trained as care coordinators / peer recovery community health workers. Staff will also include trained volunteers, especially those who are in recovery and working towards peer recovery certification. We'll also invite other service providers from various community organizations to be at the mobile site on a regular basis. And we've actually had conversations with a number of agencies about that already, and they're all very interested. Since they're wanting referrals into their programs, it works out really nicely. Mm-hmm. So we're hopeful. We'll know before next meeting where we're at. So hopefully next meeting we might be able to talk about moving on, yeah. Getting it operational. Any questions? You want to add anything, Dave?
No, I think that pretty well covers that.
Okay.
Okay, on to administration?
Yes.
Okay, fun stuff. All right, so I've been talking with the hospital and with some partners around, we've had Mason Matters. Mason Matters is currently on park mode.
Yes.
So in our discussions, we'd like to move in a different direction, in something that's much more action-oriented and bring in a larger audience. So it wouldn't be just the hospital and us and a few others. Really to try to make this something that's much more community-wide and bring in the people who have checkbooks or people they can dedicate to making things move forward. And it's really kind of based on a project we did in Padre County that started back in 2014 and is still going strong. And actually, they're identifying things and then picking them off one at a time. So for example, vaccination rates were low at Padre County, very low. But we saw that it wouldn't take much. In some of the schools, if you get 5 kids immunized, you just brought your rate up 20% because the numbers are so small in some of the schools. So we did a community-wide event And at Christmas time, it was called Festival of Trees, and the kids all got to come and see Santa Claus. But as they came through their door, they had their vaccination record checked and updated, and if they needed shots, they got shots. So the hospital provided the vaccine, public health provided the nurses, the school brought their computers. So we brought our vaccination rates up fairly dramatically in just one event. But it was a partnership using the resources we already had. So we didn't add any money to the. We just used what we had, and it's kind of a combat multiplier by working together. So that's the model we're looking at moving forward here. In talking with Eric, the initial piece of this is going to be driven by public health and probably by the hospital. So public health is going to be the convener, and Allison is going to be our lead on that. Congratulations. Allison is our health educator and assessment person, so that's perfect fit for doing this kind of work. The hospital will provide the logistics, meeting rooms, logistical support as the core two to get this up and off the ground. We'll be looking at everything. If you go through and you look at death certificates, chronic disease, diabetes, obesity are our biggest killers. Heart disease, those things, smoking, those things we know, but they're not the bright, shiny things that make the news all the time. But it's the stuff that kills us over time. So we're going to start working on those things in a coordinated community way with the schools. So that's going to be the genesis of where we're going to go from here. CPAA has funding available to support those activities as we go down the road, so that's what we're going to be tapping into. It really, we're trying to go beyond and look beyond what is happening in Cascade Pacific Action Alliance, which right now everybody is very much focused around the Medicaid transformation dollars. Well, there's a lot more community out there besides the Medicaid population, and we're not really addressing that. So I think that's the opportunity for public health to weigh in and say, you know, there's more going on here. Yes, the Medicaid transformation is an important piece, but it's not the only piece. And to try to get those activities refocused in, you know, a greater population. We have a lot of people who aren't Medicaid recipients that still have health problems. So let's start dealing with those. Education. If you look at tobacco use, for example, in 2009, the legislature swept the tobacco money into the general fund. So that was $555 million a year that was no longer being used in tobacco work. So now there's almost no money for tobacco. So as a community, we're going to have to figure out how to do tobacco work using the resources we already have. And it's going to be a kind of tough nut to crack, but I think in a group where we can bring in the schools and sheriff's office and hospital and doctors and have a couple of real champions out there in the community, we can push some of that stuff forward. So that's been a body of work we've been working on recently. CPAA, on the Medicaid funding side, is we're on our third year, so we're actually starting to get money out. So the RFPs went out, request for proposal went out in June. People have applied. We ran into some issues with the RFP process in that as we picked 4 avenues that we were going to address. Lydia and her team started working on those 4 avenues, and as you got down through the software, through the program, you'd hit a barrier that we just couldn't jump. But you didn't know that till you got through this process because of the way that this thing was set up. So you spend hours and hours of work and got to a stopping point that we just couldn't hurdle. So we scaled back from 4 projects to 1. And one project is the opioid outreach program. I took that and went back to CPAA and said, here's our experience. And everyone has similar experience. So there may be an adjustment to the process this next year as they move forward. So for those who haven't been around, it's a 5-year project. First 2 years, Healthcare Authority pays Cascade Pacific Action Alliance for reporting. So we're paid for reporting the first 2 years. We're in the 2nd year of that. Okay. As we move into the next 3 years, we're paid for performance. So they actually have to start bending the needle and have some results. So as we go into the next 3 years, our reporting requirements for us that receive the funds go up in order to show that we were actually making progress on what we said we would do. It was less. It started off as $4 billion to the state. It got scaled back, I think, to $2.4 billion over the time period. And if the state doesn't meet its target, the state has to pay that money back. So there's a lot of incentive to make sure that things move forward. That's one piece of funding. There's some other funding pieces out there. We just received our second iteration of the Foundation of Public Health Services money, which is some flexible funding that we used last year on water quality work. We're going to do that again this year. We're hiring, it's going to pay for about a half of FTE, and we have some other money we're going to put to that, so we can have a whole another person working in that kind of work. Alex, what was it, 350 acres were restored to open on shellfish, so.
Change from conditionally approved to approved.
Right. So if you look at our funding over the years and you look at water quality and shellfish closures, they parallel each other. So we're trying to get to a point where we can find some funding that's stable over time, and we can keep people out there in the field working. It seems like every time we back off, then we start having septic issues and other problems out there. We lose ground. So legislatively, we're public health through WSALFO. I'm the chair of WSALFO this year, and we're not really looking to put forward any big policy bills other than foundational public health funding. So if you take a look at all the things that public health can do, and you trim that back to what we have to do by law, those things we really have to do, that's what we're going to concentrate on. And then the other additional important services, we'll have to find that funding through the local communities. So, for example, in some communities, public health does WIC. Well, that's funded locally. That's not funded by the state, or family planning or whatever service. So we're making a very sharp delineation on some of those things now, and seeking state funding for the foundational pieces and then the community funding for the rest of it. So as we get that piece written out more, I'll bring that back. Right now it's in like the super draft form. The other thing that kind of rose in the last couple of weeks is the Cascade Pacific Action Alliance, which is a accountable community of health, and all accountable communities of health have asked for access to community health assessment tool. And it's a tool that public health uses to pull data out, and it's raw data. And there are a number of us that have some serious concerns with that happening, in that if you just take raw data, especially right out of chat, those numbers aren't, in the very small numbers, it's easy to identify the person involved. So public health, when we look at those numbers, we screen that to make sure that if it's under 10, we'll just say numbers under 10. So there's some HIPAA pieces in there. The other part of it is I really have a hard time handing raw data over to people who say are from a very populated county and don't understand what small numbers in a rural county really mean. They don't have the ability to really interpret the data.
How one event could skew a lot.
Exactly. So if you're used to having, in a small community, a suicide a year, and you have a second one, well, your rate just doubled.
Yeah.
So, but really you had just a second person.
Yeah.
So that sounds kind of cold, but that's how data works. So it sounds like public health will be able to trump that and say, no, that data needs to come through public health and be screened, and then can go to the accountable communities of health. We see it already with the accountable communities of health using county health rankings in an inappropriate way. So, for example, Mason County scores pretty low in access to physical activity because we don't have enough gyms that are open to the public.
You got mountains, buddy.
That's right.
Yeah, it doesn't mean we don't get physical activity.
Right.
Exactly.
But it's in the way they measure.
The way it's measured.
Right. So that is really the purpose of those of us who are sitting here who understand the data and try to put a realistic face on that. Otherwise, it tends to be overreported, underreported, and misreported. So we're trying to keep that face out there. As chair of WSAFO, we've got a lot of things going on. We're looking at a big money ask this next year for the foundational public health piece. It's on WASAC's ledge agenda as well, so I'll be working with Commissioner Schutte to make sure that the two things align, because right now I think we're not aligned on what we're asking for and what WASAC thinks we should be asking for. So we're going to, Commissioner Schutte and I will get together and start scrubbing those numbers now that I actually have numbers to start working from. That ask, my concern is that it's going to be rolled in underneath Department of Health's budget ask. So last year it was separate from Department of Health. So Department of Health put their budget in, and then we had this ask for $60 million, which was reduced to 12. And part of it went to Public Health, part of it went to DOH, and part of it went to Board of Health. This year, with it being underneath Department of Health's budget, gives me some concern in that the rules tend to get muddy and the money flow tends to get muddy. And one of the things WSAFO is asking is that before we sign off on this package deal, that it's clearly delineated what goes to local public health, especially to the small rural counties, because a lot of how this is written is around regionalization, and that doesn't always work for us. In the other counties I worked in, we used to have a saying, Spokane gets the cookie, we get the crumbs. And it really happens a lot to small rural health districts that surround a large metropolitan district. The money gets used in the metropolitan district because they have more numbers they can sway, and it makes a bigger difference in the data, but they tend to leave the rural populations alone. And we're really trying to break that trend and make sure that the rural populations are as equally accessible to the funding as the large jurisdictions. So we're pushing back on that a little bit. We're pushing back on making sure that it's very clearly delineated who gets what before we agree to move the package forward. So a lot of work has been done in the last 2 years to determine what the gap is. So here's how much money we're spending, and here's how much money it would take to do it right. And we're still scrubbing that data because it depends on how you report it. For example, when I sent ours in, I did it in such a way that said, if we were to do all these programs on our own, it would cost this amount of money, and not as a shared service with other counties, because I think that is the maximum it could cost. So let's look at what the worst case scenario would be, and then we can adjust from there. I don't mind doing shared services as long as it originates at the local level and it's agreements between health directors. Because when it's pushed down from us, it rarely works. When it works best is when we decide amongst ourselves who does what and how we share the services. An example of that is we're going to share an epidemiologist. So I can't afford to have a fully trained epidemiologist, but between 4 of us, we can afford one. So those kinds of things we can share, and that's a good road to head down. So it's just a matter of having some wisdom when we look at those things to see what will work for us small jurisdictions next to large population centers, because frankly some of our problems are spillover from those large population centers. So I mean, we do have to work with them because that's where the problems come from. It's going to be a busy year. It's going to be a wild ride, but it won't be dull. Any questions on that?
Okay,
Okay.
Thank you.
so environmental health report.
Yeah, so I'm Alex Pacey, if I haven't met you yet, interim EH manager for Mason County. And Debbie Riley was our old manager. She retired end of June. She announced in the last meeting. And we're sad to see her go, but we've been trudging forward. So I included my name, extension, email on there if anybody has any questions or concerns. Other than that, the only other things I was going to highlight, Dave mentioned, our classification of actually 369 acres of shellfish growing area was exciting news for us. We played a part in that. And then our new hire for water quality that's coming up that we're working on is exciting too. We've been building a maintenance tracking system since 2004 for septic systems, and slowly building it, entering in all the parcels in the septic systems and tracking all that maintenance, and this is kind of a first opportunity to have some real flexibility on what we can do with that. Despite being only half a person, still a little bit of excitement to see what we can make of this. So yeah, I'm excited to see that money come in. That's all I had though.
We know each other.
Okay.
Now, I worked with your grandfather
Oh, okay.
on the east side.
Yeah. From around here.
Yeah.
From the east side. Oh,
Yeah.
wow. Okay.
Well, before you guys moved over.
Yeah, that was 80s. Yeah.
I was in charge of the on-site program at that time.
Okay.
That's part of living here.
Yeah.
Yep.
So, your father was involved at one time. Is he still involved?
Yeah, he's still doing design work and stuff.
Okay.
Yeah.
Okay. Well, good to see you.
Yeah.
Okay. So now it says annual report.
Okay. Which is later than I wanted to get here, but here it is. What is those one let's see. I'll get mine today. Back to media, so. This is the annual report for the whole department. So you'll see that it's a combination of public health and community development.
My favorite subject.
What's that?
My favorite subject.
Yeah, there you go. So in our annual report, I'm trying to show that we're really working to integrate what we do in public health and community development. And I'll have to say that more and more I see environmental health folks upstairs talking to planners, talking to the building department, and the communication is just constantly going. It's good to see.
That was a dream 3 years ago, 4 years ago. That was just a dream that would happen. They hated each other. They really did. They would purposely send the people back and forth. It was horrible.
So I think it's working. Communication can always be improved, but it's improving. We're working. We do meet weekly with, for example, the code enforcement folks from upstairs, in planning and building, and downstairs to look at those parcels that need a coordinated effort.
Come to the city.
Well, and actually, I'm going to start coming to the city council meetings because we need to do a little more integration with the city, especially with health enforcement, because the city does not have their own health person.
Very good.
So we'll start working with the city as well. In fact, I was working with Sean Carlstrom to work on some areas where we knew that rats were nesting and to get those places cleaned up and eliminate those. And that's worked pretty well.
Very good.
So
I'll be excited to have you done.
yeah, so we're going to start reaching out to the city, spend more time with the city council and with city staff. In fact, I just met with City Public Works to talk about water and sewer and some other projects.
Good.
And to take a little bit longer view.
Very good. Thank you.
So as you go through the manual, we start off with my favorite topic always, which is finances, and break out how we look over the past year. Of course, this is 2017 numbers. We talk about public health revenue source, and that's on it says page 1. But it gives you an idea how our pie is split out in public health as a special fund. Comes from a variety of sources. You have federal sources and state and local fees, county contributions. All have a part of that. Expense, over half is always in salaries and wages. When you look at community development, let's swing over to community development. And that's at the bottom of page 3. Community development pie only really has 2 slices. I mean, it has 3, but pretty much is a 2-slice pie, which at times works great. But when you have economic downturns, community development takes the hit faster and harder than public health does because it has a variety of funding sources. So we can kind of scoot things around in public health where community development just does not have that kind of wiggle room. So we're hitting targets. We're staying below the line on expenses versus revenue. You'll see we're starting to track year over year in order to have some prediction about where our expenses come and when they'll hit us. And that's important when we look at county contributions, when we get money from the county, and then when our indirects are taken out, to make sure that we're not taking indirects out at a low point and we run ourselves cash flow. So we're tracking that over time to try to get a handle on when's the best time to pay things. So there's times when, for example, we'll pay for the audit. We always know when that audit bill comes. We always know when our insurance bills come. Those sorts of things. So try to match the revenue and try to flatten the peaks out. And keep revenue and expenses flat as we can.
It also helps some money at the end of the year that you're expected to come, not that doesn't come in because they don't think it's needed.
Right.
Gotcha.
So we're trying to flatten out the hills and valleys and make some progress there. We then go into public health. There's just a lot of data in here, and there's a
100% increase in hepatitis C. I saw that.
Mm-hmm. Yep, from 1 to 2.
Yeah, from
One
1
to
to
two.
2. Yeah.
Mhm. So, and that's a perfect example. You know, that can get reported and be really kind of out of context.
Well, the thing is, it sucks going back the other way from 2 to 1. It's only 50%.
Right.
So,
So if I were to have blinders on and you were to tell me that,
It
that increased, I would go.
Doubled.
yeah.
And then I would take my blinder off and look at the number and I go, oh, okay.
Right, and actually, I've had that happen at state meetings. That someone say, "Well, how come your statistic on this doubled?" Well, that's one case, or 2 cases. So it's, that's why I really feel that it's important that we have our own assessment people putting information out. We talk about environmental health pieces. We talk about, as you get toward the back, about the community development piece, because we really wanted to make this organization the healthy community department, because it really is. It all rolls together. You can't separate building from health. The two are intertwined. So we have a model that's unique, and I think it's working. We're going to talk about the therapeutic courts. We're very unique in the state in the pieces that we touch.
Yeah, that's a great idea. Therapeutic courts.
This is going to take some time to digest.
Mm-hmm.
Yeah.
Okay.
What is the child reunification program? They have something coming up I'm supposed to be at.
Okay.
I just didn't-
Nothing really leaps out when you look through here. On-site sewage trends. We're trending up in permits year after year. So there's more development going on. We're making more headway on operations and maintenance. We've got a really good partnership going right now with the pumpers, I think, in letting us know where the problems are. And then we have staff go out and work those problems, especially along the shorelines. There's some new technology that I've talked about a little bit that I think as time goes by will help those small shoreline lots. It's like a mini municipal sewage plant that you can drop into the last chamber of your septic system, and it will filter down to virus level.
Wow.
And basically you're putting treated water back into the ground, not effluent. So I think as time goes by and the technology becomes more available, we'll start seeing more of those on the shoreline lots. We have tiny lots that just have no space to have repairs. So we're trying to find some technology that'll fix that. Lots of good stuff.
Yeah. I think they'll fully digest it. I'm gonna have to take it home and look at
Right.
it. So any questions for Dave before we go on?
It took a little longer this year because I was trying to get our financial systems, which are different,
Mm-hmm,
to report in a way that looks the same, so you can compare things.
right.
So I think we hit it this year.
I think you did a good job. We'll find out when we get.
We'll
Going to find out when you
we-
dig into it. Yeah.
when we dig
11
into
o'clock
it,
at night.
Yeah.
One quick question.
Sure.
Because I'm new to all of this and new to looking at it. When it talks about under the community health improvement plan and the 7 priority areas of focus as identified by the community derived from the community health assessment, are those 7 things these headlines that come after it? Like the tobacco program, the
No.
public health? Okay, because I wasn't exactly counting up the right ones, so I was just curious what those 7
Yeah.
priority areas were.
And,
What page is that, Carrie?
Page 12.
Yeah.
No, it's housing, substance use, behavioral health.
Chronic disease.
No,
Nope.
no, that's under clinical, let's see, okay. Now, help me, Allison.
Oh,
Allison, yeah.
access
I'll
to
come
care.
up with them.
Well, that's,
Yeah, it's, boy, I should know these by heart.
well, part of it was economic development too, wasn't it? That was one of the,
Yeah, housing plays a piece.
yeah,
But we're talking about our 7
7.
priorities.
But I thought that,
It's
I was
actually on the
chalk.
website.
I was
I'll
just
take a
gonna
look
say,
at that.
It is
Okay.
actually
It
on-
is
that's a
on the
really good
website.
I can dive into
And
that. I mean, it is
it's-
showing that 2 of the areas chosen by the community are affordable, healthy housing and prevention and treatment for substance abuse and mental
Right.
health. I was
Does-
just curious.
Then there's an education one.
yes,
There's a access to care one, or clinical care. Access to care it is. And there is environmental health, so more of an environmental focus. So there's 7 that the community picked up. They're very broad. Our community
Okay.
went like
Yeah.
this, which is kind of good because they got, wow, everything affects health. And that's what it
Mhm.
boiled down to.
Mhm.
So, yeah.
Okay.
But it is on the website.
Okay.
and
I'll
we
take a
knew
look
that
at
we couldn't work on all 7,
Yes.
so we, yeah.
Focused
We
on
picked housing and
Not that all 7
Substance.
aren't being worked on, just not
Everything's being worked on, right.
concentrating on all
Yes.
7 at one time.
Yeah. Okay.
And if you look at housing, I mean, that's just a huge issue in trying to get, let's look around the community, just walk through downtown Sheldon, and we can see where we need it. Housing has to get addressed. So that's part of what we're working on.
Yeah, in my neighborhood.
Well, and it's not unique to us, it's
No.
everywhere, but,
Okay, safe and affordable housing, nutrition, physical health and wellness, prevention and treatment of substance abuse and mental health, empowering families, trained and prepared workforce, access to quality, timely, and local health care, and healthy environment. Those are the 6.
And
They're
the-
on the website.
The trained and prepared workforce came out of economic development.
Yes,
Because you have to be trained and prepared if you're gonna have anything come in, you have to have a workforce
And
that will,
the graduation matters and getting away from logging, we have to find new other avenues.
and then the health part of it, the trained healthcare workforce
Yes.
is difficult because it's hard to
Exactly.
keep them there.
it's hard to keep anybody with credentials in a small county. They
It is.
wanna be where they have everything.
And cross the county line and make $20,000 more right off the bat,
Yeah.
it's difficult to compete with.
Anyway, any other questions on that?
That was good.
Any other business or board discussion? Anybody would like to see anything else come? I know we're gonna have more on the opioid.
We had a spring workshop with all the commissioners in Grapeview. And there was a doctor from South Kitsap that presented several programs. One was on the regional issue of opioids and he passed out this little handout. So I thought maybe I could give this to somebody, and next time,
Somebody make copies?
yeah, but not this time. But it's very well written and puts things in perspective.
And I have been sending out some informational things. If
Yeah.
you'd like to continue to get those, I'll
Mhm.
Um,
That was an interesting one that you just sent on the opioid use and historically.
Right.
Which
Yeah.
is funny though, he's been touting that for a while.
Yeah.
And we actually brought that to Senator Cantwell
Right.
because of that, so proven right again, weren't you?
So, public comment. Okay, Tom?
Thank you. Just a couple of quick comments. Always pay attention when Veterans Courts is mentioned. We have 7.3% of the jail population. My last count was veterans. Yet we have a very low participation rate in Veterans Court because the criteria for participation in Veterans Court is so high. And I argue that constantly, but don't get very far with it. It's you have to be a convicted felon to be eligible to go to Veterans Court, as if it was something to be proud of. If we're trying at this time, working with Harris Hartel, to open up some of the programming, some of the treatment approaches to district court, and I'm hoping that we can get a little closer with felony court and maybe a little closer with the prosecutor, and we can get a little bit better participation. The programs in Veterans Court are good. Getting people in is hard. The other thing, and the only other thing I wanted to talk about was the tobacco program. If you ever found an opportunity, and we're doing the same with the DAD, to talk with the Squaxin tribe, we're talking about other issues, homeless issues and so on, but I will not be hesitant about bringing up tobacco-related issues. Now, they have an economic interest in selling tobacco products. It's a conversation that, of course, is sticky wicket, but it's about a conversation that needs to be started, at least, well, since you're bringing him in Squaxin Safe Street, if you could just throw it out there. At some point, I live in a very rural area, and all the people around me who smoke, they smoke the Indian cigarettes because it's cheaper. If they had to pay the $8-9, I think that might be motivation for them to either smoke less or to quit. But they buy them by the carton. They're extremely inexpensive compared to the brand names. And if that gets too expensive, then they buy the bags and they roll their own. Somewhere along the line, a conversation has to be started with Squaxin.
Well, that's a good point. I did a study a while back, and where there's access to either out-of-state cigarettes or tribal cigarettes, the smoking rates actually go up. Because a person goes in, instead of buying a packet at a convenience store, they buy a carton or 3 cartons because they can save $35 a carton.
Mm-hmm.
So, and if it's in the home, they wind up smoking more because it's available.
Yeah.
So it's definitely an issue that we're looking at.
When I smoked, I bought a pack. If I bought a carton, just like you said, I smoked more. So I bought 1 pack, and that was the way I kind of forced myself to control it along that time in my life. So I figured if it works for me, it probably work for somebody else too. But thank you.
Access is everything. My daughter, when I caught her smoking when we were younger, the way I did it was the old-fashioned way of actually buying her cigarettes and let her smoke much. Yeah, and it was funny because I remember asking her, "So what do you smoke?" I was just real kind of. She goes, "I smoke what all the cool kids smoke." I said, "Okay, what is that?" GPC Light 100s. I said, "Okay, well, what it was her mother, who I wasn't around, that's where it came from." So accessibility is what determines it sometimes.
Yeah, I tell people that the easiest way to quit is don't buy them and don't bum them.
Yeah.
If you don't have them, you can't smoke them. Okay, any others?
That's a big moneymaker for the Squaxins.
Yeah, it is.
Well, if you look at it statewide, the state makes an average of $555 million a year on cigarettes, just on cigarette taxes. Marijuana is now coming in a very close second and may surpass that soon.
I thought it was.
Yeah. That's right.
Yeah, but we
behind
don't
it.
get any of it. What do we
Well,
get?
and as far as the tobacco money goes, I mean, we were sold tobacco taxes as a way to reduce smoking rates and to pay for the programs that go to help intervene with smoking.
And it's-
Right now, all we get out of that $555 million is $3 million that goes to the quit line. The rest of it goes into the state general fund.
Well, at least the quit line's still there.
Yes, but that actually took a lot of work to keep that open.
Yeah.
The Department of Revenue
It-
came out with a statement saying that, you know, cigarette taxes are the state's 5th largest and most stable source of income.
I kind of thought the quit line was down for a little while.
It was.
Yeah. So, anyway, anything else? Shall we adjourn?
Will we adjourn?
Okay, let's adjourn. It is now 3, we did good.